you guys waiting 15 minutes. All right. So the first question will be EEG in pediatric epilepsy. Okay. So these are the topics under which we'll be discussing. We will talk about introduction. If such a question is, how are you going to start? Then the basics of EEG. How are you going to prepare patient? Indications and contraindications. Any specific preparation or activation is required for recording the EEG. Some characteristic EEG changes. Reporting of the EEG, pitfalls and conclusion. So these are the topics under which I'll be discussing. Right. So what about introduction? Introduction, you tell what EEG, you tell what is seizure epilepsy convulsion. EEG is recording of the neuronal dysfunction, recording the abnormal cortical excitability. All right. So this is EEG. What is your seizure epilepsy convulsion? Seizure is abnormal synchronous or asynchronous electrical discharge in brain. Convulsion is the physical manifestation of an electrical discharge. Epilepsy is the propensity to go on to have multiple convulsions or seizures in the future. Very simple definitions. Okay, so this will be your introduction. Then principle of EEG. What is the principle of EEG? EEG is trying to record the potential difference, electropotential difference between 2 points in the scalp. How are these 2 points kept? They keep electrodes. How many electrodes? They keep up to 21 electrodes in older children, and younger infants and neonates, at least 12 electrodes are kept. And these record the electrical discharge from pyramidal neurons in layer 3, 5 and 6. These discharges are modified by your thalamus and brainstem reticular formation, and that comes out as your EEG recording. So technical effects wise, you saw minimum 21 electrodes in older kids and minimum 12 electrodes in neonates and young infants. EEGs are going to detect what is on the topmost area. It will not detect what is deep down, what is happening deep down in the brain. Electrodes naming is pretty simple. Okay, it looks complicated, but it is actually simple. Remember the 4 lobes: frontal, parietal, temporal, and occipital. One more extra, frontopolar. Then if it is going to be a central electrode, then you will add Z to the previous letter. If it's a reference electrodes are kept behind the ears both sides, and they are named as A1 and A2, representing post-auricular, A1 and A2. Odd numbered electrodes means it's placed on the left side, and even number electrodes means they're placed on the right side. So this will be your basic of EEG. What about patient preparation? Patient preparation, ideally you should know the indications. Okay, so indications is given in the back of this article, so we will go along with the article. So in patient preparation, you should educate the parents that this EEG recording is going to last for at least 30 minutes. This EEG should include a hyperventilation for 3 minutes at least, and intermittent photic stimulation. Photic stimulation of 1 to 30 Hertz frequency. It can detect epilepsy in juvenile myoclonic epilepsy. Okay, and long-term video EEG recordings are important if you are going to do a epilepsy surgery. Sleep deprived EEG means 4 to 6 hours of sleep deprivation. So these are various methods by which a EEG can be done. All right. So you do regular EEG for 30 minutes, including hyperventilation, including sleep deprivation required, including a stimulation or a reflex epilepsy testing. Okay. So this is patient preparation. This activation process your sleep deprivation, your photic stimulation and all that. So you do a sleep EEG record for finding out focal epilepsies. You do an awake EEG record to find out generalized epilepsies. Okay. Activation procedures are hyperventilation. What will hyperventilation initiate? A absent seizure. Correct. Intermittent photic stimulation is juvenile myoclonic epilepsy. Fixation of sensitivity. Fixation of sensitivity means when the eyes are closed, then occipital waves start. When eyes are open, occipital waves are absent, epileptiform waves. So this is seen in late onset occipital lobe epilepsy. If the seizure is characterized in history by precipitation, precipitated by a trigger specifically, then you try to give the trigger to the patient and see if it's going to record a epileptiform discharge. For example, video watching. So that can result in some reflex epilepsies. If you think it's a non-epileptic event, then try suggesting to the patient that you may have a seizure now and see if the patient is going to have a seizure. So this is your activation procedure. Then skip the EEG interpretation part in your article. The pitfalls of EEG, you can write it down below when you're writing your answer. But the pitfalls are, one, the EEG can record only what is happening on the surface. What is happening deep below, the EEG will not be able to find out. So epileptogenic focus, which are deep in the brain, may not be picked up. And few genetic epilepsy types like benign familial neonatal epilepsy and benign familial infantile epilepsy can have non-epileptical EEG despite the child having convulsions. Epileptiform discharges can be found in normal healthy children also up to 5%. Okay. And EEG can be abnormal in 6 to 60% in children with autism, even though they do not have convulsions. They do not have clinical seizures. Okay. So these are all some of the points that we need to remember. And when you're doing a photic stimulation, you can see photic stimulation waves in migraine patients without any epilepsy. So these are all the pitfalls. So only surface changes will be recorded. Normal patients can have abnormal EEG. Abnormal children can have abnormal EEG without convulsions or epilepsy. And photic stimulation can result in wave changes in migraine patients. Okay. Then you have a table of essential component of an EEG report. So here the history is important because epilepsy is a clinical diagnosis. Okay, epilepsy is not diagnosed by EEG. Okay, so in fact, that is one of the reasons why you should not do a EEG. All right. Technical details wise, you have already talked about it. You need not go into details. Whenever EEG is being described, it will describe two things basically: background and if there are any epileptiform discharges. Background waves. What is the cerebral activity when the patient is awake, when the patient is asleep? When the patient is awake, you are seeing with your eyes. So it will be occipital predominant wave. Okay. When you are sleeping, sleep markers will be present depending upon the age. If there is going to be abnormality, then that abnormality will be explained. Where is it? Is it in the frontal, temporal, occipital lobe, or is it in the right side or the left side? What is the frequency? What is the voltage? So those things will be explained. Then if background is normal or abnormal, you will add on epileptiform discharges. Epileptiform discharges, there are certain epileptiform discharges which are specific for certain types of epilepsy. So come to the next page. So only important seizures I will be talking about. Benign neonatal seizures or fifth day fit. Here, patient will have focal rhythmic theta activity with sharp waves called as theta 0.2 alterans. This is seen in 60% of the patients. Theta 0.2 alterans in benign neonatal seizure. Okay. Then absence epilepsy, you know, 3 spike and wave discharge, especially with frontal dominance. Okay. Then benign epilepsy with centrotemporal spikes, as the name suggests, it's going to be in the centrotemporal region. Important Lennox-Gastaut syndrome, you can have visual hallucinations and colored circular patterns as the presentation. This is where you see this fixation off sensitivity and fixation on sensitivity. Fixation off sensitivity is where occipital spikes will be seen and sharp waves will be seen when the eyes are closed. When the eyes are open, these waves disappear. Okay, so this is seen in Gastaut syndrome. Then absence epilepsy, juvenile absence, you know the waves are more. Juvenile myoclonic epilepsy, photic stimulation increases. If these many classical EEG findings you remember for epileptic syndromes or epileptic seizures, then that's more than enough. Okay, so these are classical features. Next table, you have few more EEG features. If you have time, you can go through that. We will see box 1 seen in page 6. Okay, the indications for EEG and when not to use. This is important. When to use EEG, if you have to differentiate between an epilepsy versus a non-epileptic event. If you find an epilepsy, you want to know whether it is a focal or a generalized. And you want to know whether it belongs to a specific syndrome or not, because you need to know the prognostication, right? And you can help the neurologist decide on what sort of epileptic drugs might be useful. And after initiation, when should the drugs be tapered? Okay. So these are all common indications. Some later on indications will be if the patient is having a meningoencephalitis and if the patient is having a herpes simplex encephalitis, then patient can have periodic lateralized epileptiform discharges called as PLED. PLED, PLED. Okay. In children with cognitive or language regression, it is still important to do EEG to rule out Landau-Kleffner syndrome, because they can present even without seizure just as a language regression. So these are all the indications where you should be using it. In ICU settings, you want to differentiate a patient in coma as a metabolic coma or an encephalopathic coma versus a non-convulsive status epilepticus, and that is one other indication where you will do a EEG. When not to use a EEG is for diagnosis of epilepsy, for excluding a diagnosis of epilepsy, because epilepsy is a clinical diagnosis. You want to monitor the progress of epilepsy, you want to monitor the efficacy of anti-epileptic drugs. It's not useful, and only in specific indications it's going to be useful. ICSOL, intracranial space occupying lesions. You don't have to do an EEG to decide whether you have to initiate an anti-epileptic drug or not. You will initiate an EEG when you find a space occupying lesion. And when you sure know that the patient is having a non-paroxysmal event, then non-epileptic paroxysmal event, then you don't do an EEG, because you know by history and examination it's definitely not epilepsy. So this then you will not do a EEG. So that's it about EEG. The key messages part you can write as conclusion. A normal EEG will not exclude a diagnosis of epilepsy, and EEG report should always be interpreted in the context of clinical history and examination. So this is about EEG. So first question is done. The next question was your antibiotic resistance, right? Approach to antibiotic resistance. See, I'm doing these sort of classes because one, it will be useful to you and me, obviously. The other reason is we generally do not have the habit of writing fast, and we do it for the first time after 2 years or 3 years sitting in an exam. And the first exam might be easy, but as you go through, you find that your wrist sort of give way and it becomes very tired. It becomes difficult to continue. So I would suggest take notes where you not have a backup material like this article. So you get the habit of writing first, because each question you have approximately only 8 minutes if you have 20 questions per paper. Okay, if you have one 10-mark question, then yes, for that question you can spend 12 to 15 minutes. But if it is 20 questions per paper, then you will have only 8 minutes to answer each question. So be fast. Right, now coming to methods of antimicrobial resistance or antibiotic resistance. So if this question is repeated, then start with an introduction saying antibiotic resistance is one of the most important causes for morbidity and mortality. And this has resulted in a need for antibiotic stewardship. WHO came with a global action plan to curb this antibiotic resistance. Okay, so antibiotics act by different mechanisms of action. Few act by cell wall synthesis inhibition, few act by cell membrane depolarization, few act by protein synthesis inhibition acting on the ribosomes, few act by inhibiting nucleic acid synthesis, and few actually act directly on the metabolic pathway of the organism. Okay, so cell wall synthesis inhibitors, example is beta-lactam. Your depolarizer example is a lipopeptide. Your protein synthesis inhibition classical is aminoglycoside. Nucleic acid synthesis inhibition is a quinolone. Metabolic pathway inhibition is your sulfonamide. These are classical examples of different mechanisms of drug action. What about mechanisms of resistance? Resistance can be broadly classified into two. Okay, so what is resistance? The antibiotic is not effective against stopping the organism from multiplying. The minimum inhibitory concentration has increased. Okay, so this resistance can be natural or acquired. All right, natural resistance can be divided into intrinsic and induced. What is intrinsic? Intrinsic is where the organism has genes giving the capacity against the antibiotic, and it is always expressed. Okay, so the gene for antibiotic resistance is always expressed in intrinsic. Induced is the gene for antibiotic resistance is present, but it is expressed only in certain conditions, like when the organism is exposed to the antibiotic. Otherwise, it is present. So example of your intrinsic resistance is, for example, lipopolysaccharide membrane. So that is impermeable to certain antibiotics, and it is always going to remain impermeable because it is a lipopolysaccharide membrane, like in gram-negative organisms. Efflux pumps. Your gram-positive organisms, for example, are intrinsically resistant to your Aztreonam. Aztreonam does not help against gram-positive organism. E. coli are intrinsically resistant to macrolide. So these are all some specific examples. Inducible, as I told, it is expressed only when the organism is exposed to antibiotic. What about acquired? See, acquired resistance can happen through multiple mechanisms. Most of them are by horizontal gene transfer. So from one organism is already having resistance, is giving the resistance to another organism. It can be by transformation, transposition, conjugation, etc. From where are you reading? I'm reading out from my notes. Okay. So these are my notes which were taken long ago, so long ago, and it kept on adding, and now I'm just reading out to you guys. So this is, I want you to take notes. Okay, so that's the reason. So these I will not be explaining because this can be found in microbiology books, and this is not important for writing this answer. For this answer, you need to write how these genetic transformations actually result in antibiotic resistance. See, genetic changes happen, but what does a genetic change confer? It can either result in decreased drug uptake. Okay, so the organism might not take up the drug inside at all. It can modify the drug target, or drug can be inactivated completely, or it can take in and spit it out by efflux pumps. These are the four mechanisms of antibiotic resistance. Secondary change. Got my point? Intrinsic resistance generally use all mechanisms except your modification of drug target. Your acquired resistance use all mechanisms except your decrease in drug intake. Okay, the drug uptake, you can tell. Yeah. So these are the mechanisms of resistance, and gram-negative usually uses all these four mechanisms, whereas gram-positive does not, work much through the decreased drug uptake. Basically, because decreased drug uptake is classically a function of lipopolysaccharide membrane, which is seen in gram-negative organisms and not in gram-positive organisms. Okay, and what has resulted in these genetic changes happening and these resistance happening? It's because of increased antibiotic usage. Increased antibiotic usage both in humans and in animals. Animal foods, animals are injected, so that has resulted in resistance. Improper prescriptions, where a viral infection may be prescribed an antibiotic, or a bacterial infection may be improperly prescribed unnecessary antibiotic. It could be a broad spectrum antibiotic, it could be an antibiotic that does not help at all, but ultimately results in resistance. So these are all the reasons. We will talk about each of these four mechanisms, just 4 points. That should be more than enough to write a 5-mark question. Decreased drug uptake, as I told, it's a lipopolysaccharide membrane seen in gram-negative organism. Examples, some of the examples that I can give, decreased drug uptake are 1, your lipopolysaccharide, 2, your mycobacteria. Okay, mycobacteria have lipid walls, so any hydrophobic drugs will enter, whereas hydrophilic drugs do not. Mycoplasma do not have cell wall at all. Okay, this is mycoplasma, not mycobacteria. So mycoplasma do not have cell wall at all. Since they do not have cell wall, any cell wall synthesis inhibitor antibiotic is not going to work. You need to slow down a bit. Okay. Biofilm formation is the another example. Biofilm formation can be from a single organism like Pseudomonas or multiple organisms. This biofilm again will prevent penetration of the antibiotic into the organism and even into the surrounding itself, I can say. So these are all examples of decreased drug uptake. Next is drug target modification. Drug target modification, classical example all of you know is your gram-positive organisms having a change in penicillin binding protein. Okay, classical example. Another example is protein synthesis inhibitor antibiotic suddenly is not working against that organism. Then this organism could have had a ribosomal mutation or a ribosomal methylation. So this is the target for the drug, and this target is modified, resulting in the drug ineffective. Next, drug inactivation. So drug inactivation can be 2 mechanisms. One is actual degradation of the drug, and 2, chemical group can be added to the antibiotic. Actual degradation is your classic beta-lactamase, your carbapinamase, which is a type of beta-lactamase. Carbapenemase is of two types. One is Klebsiella carbapenemase and another one is carbapenemase resistant enterococci. Klebsiella, what happens is, though they secrete this beta-lactamase, they will still respond to you adding a beta-lactam inhibitors. Whereas your enterococci do not respond to you add beta-lactam inhibitor. This is the New Delhi bug. If you remember a few years ago, you must have heard, no? New Delhi bug multi-drug resistant. So that's the carbapenemase resistant enterococci. The chemical group transfer can be by acetyl, it can be by phosphoryl, it can be by adenyl group addition. Most common is acetylation. Then drug efflux pumps is commonly seen in gram-positive organisms where the drug is extruded. Conclusion, you can tell rational prescription of antibiotic is important. Antibiotic stewardship should be followed in every practitioner, every ward, every prescription station and every ICUs to prevent further antibiotic resistance development, and this is the need for R. So 5 marks, I think you can definitely cover from this. Okay, so this is antibiotic resistance. Next, which question would you like me to discuss? So we have covered 2 questions in the past 20 minutes, 10 minutes. That is the amount of time you will have to actually write an answer. So shall we discuss CPAP? Are you guys ready for discussing CPAP? Okay. All right. So let's start. So CPAP. If CPAP question is asked, you are going to start with an introduction. What is CPAP? CPAP is continuous positive airway pressure. So this is continuous positive pressure both during inspiration and expiration. In other words, this is just giving PWP. Okay, expiratory pressure, positive and expiratory pressure, you continue to give to the patient both during inspiration and expiration. So how does a CPAP work? So this is you can find a nice flow chart in AIMS protocol CPAP. If you have downloaded that, you'll be able to see the green one, not the blue one. Okay, so in green one where you will have a nice flow chart. So CPAP basically works by few mechanisms. So one is it prevents the collapse of alveoli. So what does this prevention do? This prevention keeps the alveoli open, increase the recruitment of alveoli, increases the functional residual capacity, increases the surface area for oxygen transfer. So this results in improvement in oxygenation and improvement in carbon dioxide going out. It will stabilize the chest wall. This results in reduction in airway pressure. It will splint open the upper airway. So upper airway, if it is going to be continuously open, what happens? Apnea reduces. Obstructive apnea reduces. Then the lung is stretched, your pleura, upper airway is stretched. This will stimulate your stretch receptors. This stimulation of stretch receptor again results in decreased apnea, both central and mixed apnea. So these are the mechanism of action. Ultimately, CPAP results in what? Increased PaO2 and decreased PaCO2. Improves the pH, improves the oxygenation, improves the ventilation of the patient. What are the components of a CPAP? Components of a CPAP are you need to have a gas source. You need to have something that generates a pressure. Then you need to have a system where you can connect to the patient. The patient interface is important. Okay. So what are the, just a second. Sorry. So pressure sources of CPAP can be continuous flow devices or variable flow devices. Continuous flow device is what we generally use, your bubble CPAP. Okay. Your variable flow devices is going to help the child breathe out more easily compared to your continuous flow CPAP by mechanism of fluidic dip. Okay, fluidic dip, where the flow will dip when the patient is breathing out. Okay, when the infant has to exhale against an incoming gas flow, the fluidic flip will assist in exhalation. It will reduce the work of breathing of the child. So these are the two mechanisms. What about the patient interface? Patient interface can be of 4 types. One is nasal prongs, 2 is nasopharyngeal prongs, third one is just nasal cannula, and fourth one is nasal mask. All have their own advantages and disadvantages. Anything that is pronged, anything will have a problem of your nasal septal injury. Whereas your nasal mask does not have that problem. Indications of CPAP. CPAP indication, see, if you have worked in a unit, just remember what conditions that you used a CPAP for. Then you will have your indications. Most common indications that you use is in a preterm baby having respiratory distress syndrome, a preterm baby who is having an apnea, a preterm baby who is having a sepsis respiratory distress due to pneumonia, a post-extubated baby. Just before being off to room air, you try to put the baby on a CPAP. A transient tachypnea of a newborn who's not settling down, who's still having some requirement of positive pressure and oxygen, right? So these are the common indications where you will be using your CPAP. And then what else? So these are the indications. Contraindications wise, where you will not be using, if the patient is having a facial anomaly, a palatal anomaly. You will not be using CPAP if the patient is having a congenital diaphragmatic hernia. You will not use a CPAP if the patient is not able to breathe spontaneously. Like if the patient is having a persistent apnea, if the baby is encephalopathic, not breathing properly, then CPAP is not going to help. CPAP is for somebody who is breathing spontaneously, who is having a good respiratory drive. Otherwise, no. So this is contraindication. What are the settings? The settings are flow and your FiO2, your pressure, correct? So flow wise, you're going to set it on your oxygen flow meter. Your humidification should be 100%. Your temperature should be 37 degrees Celsius. Your pressure that you start and your FiO2 that you start will depend on the condition for which the patient is initiated on. Suppose the baby is having a respiratory distress syndrome, a preterm baby. Then you start at a slightly higher pressure, maybe 5 centimeter of water, and a FiO2 of 40 to 50%. If the baby is being put on CPAP for apnea, then there's nothing wrong with the oxygenation of the baby. Baby is just having problem keeping the airways open. So you do not go for a higher FiO2 or a higher pressure. You start at almost normal 21 to 30% FiO2 with a CPAP pressure of around 4 centimeter of water. Then you will adjust according to how the baby needs. So monitoring wise, you will make sure the baby is having proper vitals. You will write heart rate, respiratory rate, temperature, pH, SpO2, all of these things you will write. You will monitor for CPAP belly. CPAP belly, in order to avoid, you will put a OG tube and keep the end open. No point keep putting a OG tube and closing the cap. You have it open, so the air that enters your stomach goes out, isn't it? So that has to be open. Then monitoring we finished. What else is left out? Weaning from CPAP. Before weaning, you consider CPAP to be effective if the baby is comfortable, has no chest retraction, normal vitals, normal PO2 of about 92 to 95%, and normal blood gas. Normal blood gas is PaO2 of 50 to 8 millimeter of mercury, PaCO2 of around 35 to 45, sometimes even permissive hypercapnia can be allowed, pH of about 7.35 to 7.45. Weaning will be done when the indication for which CPAP was initiated has gone. That is no longer. For example, if you're initiating for apnea, if the baby is not having any apnea for the past 24 to 48 hours, then you can remove CPAP. If the patient is, weaned off a ventilator, then on minimal settings of FiO2, minimum pressures, if the baby is not having any distress, then you will wean off. Whenever you wean off for the next 24 hours is crucial, and you will monitor the baby closely. And always you should wean pressure before weaning of FiO2. If the FiO2 is less than 50%. If the FiO2 is more than 50%, bring the FiO2 to 50 and then reduce pressure. Failure of CPAP is considered if the FiO2 requirement goes above 60%, the pressure requirement goes above 7 centimeter of water, or if the baby is having recurrent apneas, having respiratory distress in the form of retractions, nasal flaring, grunting, and PaO2 does not improve. It's always below say 60 or 50 millimeter of mercury. PaCO2 keeps on rising. Then these are all indications that CPAP is not working. Okay, so these are all the important points for CPAP. So I think we have covered everything. Indications, contraindications, when to start, how to wean, the mechanisms and pathophysiology of CPAP. I think this is enough for your 5-mark questions. Okay, so CPAP is done. Next is what? What was our next question? I forgot. Can somebody tell? Wait, I think it's growth hormone, right? Right, I think it is growth hormone. So I'll start with growth hormone therapy. Okay, so just the therapy part I'll be talking. Most of the points are there in your Nelson. Thank you. Growth hormone, I remembered. So most of the points are there in Nelson. Okay, few from advances in pediatrics and few from articles I've taken. Okay, CPAP was mainly from your AIMS protocol, your antimicrobial resistance, something from here, something from there. Few articles I mixed and matched and I gave it to you. And EG in epilepsy was the article that I told earlier. Okay, so let's start with growth hormone therapy. So growth hormone therapy, earlier they used to do cadaveric extracts, and that had the of Creutzfeldt-Jakob disease. But now it's recombinant growth hormone, and that does not have that risk. So recombinant growth hormone, it's available as a subcutaneous injection. Daily injections are preferred compared to thrice weekly injection, which was done earlier. The treatment of growth hormone in therapy, if indicated, has to be initiated as early as possible and as soon as possible the diagnosis is done. Because the earlier you initiate, better the rate of height gain and better the children catch up to their peers. The dose of growth hormone generally varies according to indication. Usually it is between 0.16 to 0.24, 0.16 to 0.24 mg per kg per week. This is divided for the whole 7 days. So this is for per week. This is divided for 7 days and given subcutaneously. Higher doses, even up to 0.4, 0.5 mg per kg per week in some indications, especially where growth hormone is being given for a non-growth hormone deficient infant. Okay, and during puberty, higher doses might be required. So these are the indications. Next, the indications for growth hormone therapy. Okay, I will not talk about the hormonal indications because that varies depending upon the actual syndromes. The FDA approved indications are only 8. Okay, growth hormone deficiency per se, that's a given. You have to give growth hormone. Turner syndrome and Noonan syndrome. Easy to remember these two because both go hand in hand. Then chronic kidney disease before renal transplant. Then small for gestational age baby, idiopathic short stature baby, a Prader-Willi syndrome, and SHOX gene mutation abnormality. The SHOX gene is SHOX. Okay, SHOX gene mutation abnormality. SHOX and Noonan syndrome are a little bit recent additions. It was not there for the past few years. It added recently. There are few other indications FDA approved, but still they are might be considered sort of like in few skeletal dysplasias, thalassemia, cystic fibrosis, hypophosphatemic rickets, even sometimes. So those are all considered. We will talk about each of the indication a little bit, and then we will go to complications of therapy. So in hypopituitarism, you do a provocative test and confirm the presence of growth hormone deficiency. The cutoff varies. Some papers say 7 nanogram per ml and some say less than 10 nanogram per ml. Important point to note is a provocative test cannot differentiate a partial growth hormone deficiency and normal children. Sometimes normal children have a subnormal growth hormone response depending upon the pre-existing or underlying conditions. So it cannot completely say, yes, this person is growth hormone deficient and they need growth hormone therapy. Okay, so these are all the pitfalls of provocative therapy. So, and when you are going to give, you give it in the dose that we discussed. Maximum response will be seen in the first year. Maximum response as in height velocity. It will reach up to 95th percentile. When I say 95th percentile, it is not height, it is height velocity. And as the years go by, the height velocity slowly starts reducing. If the height velocity is going to fall below 25th percentile, you will evaluate to see if the patient is actually adherent to growth hormone therapy. And if the patient is adherent but still not achieving the height velocity rates, then you will increase the dose of growth hormone. You might also need to increase the dose if the patient is, reaching puberty. When the patient's height or rate of increase is less than 1 inch per year, or the patient has achieved target height, or the bone age, not the chronological age, the bone age is 14 years in females or 16 years in males. If the patient has reached that point in time, then you will stop growth hormone therapy. So this is for your hypopituitarism. Then Turner syndrome wise, short stature is due to X chromosome deficiency and ovarian dysgenesis, which results in decreased pubertal spurt. Okay, so both are there, but growth hormone is usually sufficient in Turner syndrome patient. More than 8 years in Turner syndrome, along with growth hormone, you should start sex steroids also, because just without growth hormone, hormonal replacement therapy, earlier epiphyseal fusion will be there, and ultimately achieved height might be less. If both are given together, then the ultimate achieved height will be more. This is about Turner syndrome. CKD wise, chronic kidney disease, it has to be initiated before renal transplant. The short stature reasons are multitude in CKD. It can be acidosis, it can be malnutrition, it is renal osteodystrophy, growth hormone resistance can be there to some extent, insulin-like growth factor can be reduced. And here higher dose might be required to keep the insulin-like growth factor at a higher level. If the patient is having a subnormal growth velocity and not short stature, then growth hormone can be given. Prader-Willi syndrome, you can give growth hormone provided patient is not severely obese and does not have respiratory impairment. If the patient is having these, then it is contraindicated. Small for gestational age, again, this is a controversial area. Indication for growth hormone if there is no catch up at 2 years of age. So you wait in small for gestational age compared to rest of the indications where you initiate as early as possible. Idiopathic short stature, if the height is less than 1.2 percentile and the predicted height is less than 5th percentile and the patient is having open epiphysis, then you can initiate growth hormone therapy. So these are all the indications and few small points about each of the indications. Complications of growth hormone therapy, they are not much. Previously, the patients can have glucose homeostasis abnormalities, but after initiation, they usually normalize. Growth hormone therapy can increase the risk of type 2 diabetes, not type 1. Okay, so they can cause hyperinsulinism, but not type 1 diabetes risk. It's a type 2 diabetes risk. The patients can develop adrenal and thyroid insufficiency. As growth hormone is initiated by mistake in a patient who is having a panhypopituitarism or multiple pituitary hormone deficiency, they can go on to have adrenal crisis, hypothyroid crisis, and it can be fatal. So it's always important to rule out those and monitor for these during the course of therapy. Patient can have a risk of pseudotumor cerebri, increased intracranial hypertension, especially in the first 4 months after initiation of therapy, especially in CKD patients. There can be hip pains, ankle swelling in patients initiated. Slipped capital femoral epiphysis is common, especially the first few months of therapy. There is this question about second neoplasm. This second neoplasm or risk of neoplasm is documented in few case reports and who have had previous cancer. So in cancer survivors, if they are initiated on growth hormone therapy, there have been few case reports of patients having cancer, right? There is increased risk of hemorrhagic stroke and 30% increase in mortality in adults who have received growth hormone as children. So these are all the complications and risk factors in growth hormone therapy. To add on a point, insulin growth factor is also available in recombinant form, mecasermin, that can be given in patients who are deficient. Primary insulin growth factor 1 deficient patients can receive this recombinant therapy. So that's about short stature. I think we have discussed all 4 questions, right? And we are definitely over and above our time of 30 minutes again. All right, so that's it for today. Hope this was useful to you. If you have any more questions, you can ping me in the Telegram group Pediatric Takes. I'll definitely answer. I hope this is available for watching on YouTube. Today there was more difficulty compared to yesterday. I don't know why. So let's see. Or else I will try to trim the video somehow and put it up before. Okay. And tomorrow, 6 o'clock, I will not give a link. I think I will come directly live That might be easier. Let's see how it works out tomorrow. Okay. So I will come live tomorrow on YouTube and we will discuss the questions I'll be putting up in group. Tomorrow, I think, will be IAP guidelines discussion. Maybe we can do HUS and Gotcher's disease, end of life care. So those are all some questions that are slightly dicey to answer. So let's see about them tomorrow. Okay. So questions I'll definitely put up in the group. Bye bye. Take care and all the best.